Die omstrede wetsontwerp op Nasionale Gesondheidsversekering maak steeds opslaa in die nuus. Voor ons dit bespreek, bring ons jou gou op hoogte. Die Parlement se Gesondheidskomitee, wat hoofsaaklik uit ANC-lede bestaan, jaag om sy werk te voltooi om die sogenaamde NGV-wetsontwerp 'n stappie verder te voer. Die doel is om dit deur die nasionale vergadering goedgekeur te kry voor die ANC se verkiesingskonferensie volgende maand plaasvind. Indien dit wel gebeur, sal die wetsontwerp daarna aan die Nasionale Raad van Provinsies voorgelê word. Die NGV is sedert 2007 op die ANC se politieke agenda en vorm sedertdien prominent deel van die party se verkiesingsbeloftes. Die regering wil verseker dat alle Suid-Afrikaners goeie gesondheidsdienste van beide die openbare en privaat sektore kan bekom, ongeag hulle maatskaplike en ekonomiese status. Die wetsontwerp stel ingrypende finansieringshervormings voor, wat sal beteken dat 'n sentrale NGV-fonds vir dienste deur geakkrediteerde verskaffers sal betaal. Daar is ook omstrede bepalinge wat die rol van privaat mediese skemas drasties sal verklein. Die Parlement se Portefeulje-komitee oor gesondheid oorweeg die wetsontwerp al sedert Augustus 2019. Volgens die komitee-voorsitter Kenneth Jacobs is die einde in sig, met slegs 2 vergaderings oor voordat die komitee voorgestelde wysigings aan die wetsontwerp sal opstel. Die adjunkt-direkteur-generaal van die Departement van Gesondheid, Nicholas Crisp, het vroeër vanjaar onthul 44 spesialistposte sal die maand vir die skema geadverteer word. Om die mense in diens te neem, sal R30 miljoen kos. Die departement beplan ook om meer hulpbronne in die 2023-24 boekjaar beskikbaar te stel om nog 120 mense aan te stel. Indien die wetsontwerp deur LPS goedgekeur word, sal die minister van Gesondheid, Joe Pagla, na die ANC-konferensie aan afgevaardigdes kan bewys dat die huidige administrasie vordering maak met die implementering van die beleid. Die gesondheidsekonoom Prof Alex van den Heever sluit nou by my aan. Alex said the big missing pillar is still how the National Health Insurance, the NHI, is going to be funded. Do we know?
No, we don't. There has never been a financial feasibility analysis of the underlying premises or the kind of the approach that is being put forward. The idea that was originally placed in the green paper and thereafter kind of reflected in all the subsequent papers was that they would raise taxes equivalent to the value of contributions to medical schemes and add that to the public sector budget. And that is a oversimplification of public finance capabilities within South Africa. You can't do that. You can't increase taxes by that level. And it's to cover essentially a group of people that are already covered spending their own money. So it makes no sense, and there has never really been a feasibility analysis to see whether the taxes that they would increase would actually be able to raise those funds, and whether the substitution effects, whether or not the money they raise, would actually result in people not being willing to contribute to a medical scheme anymore going forward.
So the minister has said that medical service providers, in this case private medical service providers, will not be able to dictate terms of what they charge. But that seems to be a basic principle of a free market.
Well, actually, in many markets, markets themselves are sort of self-regulating and determine prices because there's competition. That would be market-based principles. The issue is that in the public sector, the state hasn't been able to control the costs of staff costs and the wage bill and the public health system, where in fact government does control, supposedly, those costs, and they're determined in a central bargaining chamber. Those costs have ratcheted up over the last few years. So the idea that somehow this system is going to result in an outcome that's different to what occurs for salaried staff within the state, where you've got unions that are politically connected, demanding increases that are way above inflation and in many cases have ratcheted up over a short period of time. So the idea that you control prices when people can gang up on any kind of single purchaser, and it's important to note that the public sector is a single purchaser. It is supposedly a monopoly. It can buy these services theoretically through a single fund. That's the state as it stands now, and it can't control these costs.
So the minister has also said, over time, as the fund covers more comprehensive benefits, there will be no need for medical schemes. Does the minister think that these skilled individuals who are working in the private sector will just migrate seamlessly into this new system, given news reports that we've read, and also the horrendous working conditions in some of our state hospitals?
I think, quite simply, the minister doesn't know what he's talking about. In his head, clearly, and in this policy framework, there is an oversimplification of the health system and what they can do. You can't really do what he's claiming they can do, which is effectively to prohibit the existence of private medical schemes and private insurance as a form of payment. They're not in a position to do that. They will never succeed in the courts in being able to do that. And it won't, and the actual mechanism by which they think they would achieve it can't actually be implemented. So my problem, and I think this is a fundamental concern with the overall reform framework, is it appears that the people who are key decision makers in this process are so out of touch with the health system as it is, that they can't make reasonable policies, and yet they're pushing forward on a policy they themselves don't fully understand.
But isn't that the bottom line? Government should rather focus on the system that they do have, because most South Africans are serviced by the state when it comes to healthcare. To rather say, let's fix that until we embark on this massive project.
Well, firstly, they should never embark on this project. As a systems design, it's a bad design. It doesn't make sense. But yes, we should be regulating our private system properly, and the frameworks have been developed, and we need to basically restructure the public health service to prevent the pillaging of the state services by politicians. And I'm afraid that that part, the fact that we have a sort of a gap in the system that allows for political interference in procurement systems, which is not going to change. They're proposing that to continue with that in the NHI framework. That's the one thing that never changes, and they won't touch it. So the problem is that the failures of the public system are related to the fact that we have political interference in the state services, in public hospitals, in the appointment of hospital CEOs, in the appointment of people who are running supply chain management. That you can't have. And the best health systems in the world don't permit this. But that is not on the table. What's on the table is a sort of a rather crude funding model in which the people who would supposedly procure health services through the state are all political appointments. And we know where that goes. And the fact of the matter is that that's the one particular policy variable that won't change paper after paper after paper.
So if I understand you correctly, you're saying that in this bill, there's not adequate checks and balances to prevent corruption.
So how you prevent corruption is through the sort of separation of powers, a clear design, an institutional design that says, here's what your role is. You can't have that role because it will be a conflict of interest. And the state is a great big piggy bank. And the health system is a great big piggy bank. So you have to be very careful in the institutional design to keep people away who are in a position of conflict. And politicians are in a position of conflict. They cannot be permitted to appoint people into administrations and into the running of hospitals and services. And that's why our public system is failing. And none of that will change with the bill.
Then just very shortly, for South Africans that are concerned, when will the system be implemented? What's the time frame?
Well, they've been talking about it since 2007. I'll give you a sort of my assessment of it. I don't believe that they will ever implement any real aspect of this. It's very possible that a bill might be passed, but the many bills have been passed by the National Department of Health, and they've been taken to court and struck down. They don't get implemented properly. So this is really not a very implementable policy framework, and I don't believe that the bill will properly be taken forward. But it's quite possible it will be passed, but the actual institutional mechanism and the financing mechanism will never happen.
Alex, thank you so much.